Okay guys, so today I'll be taking you through how I study for an exam. And so this is what I would do as soon as I get like my class material. I'll start off by doing practice questions just to get a familiarity with all the material and all the content, how to differentiate practice questions, and then like the different answer choices and knowing which one's right and why those are right and why the ones that are wrong are wrong. So we'll jump right into it. Okay, so a 62-year-old male presents to the clinic complaining of progressively worsening exertional chest pain and episodes of lightheadedness, particularly when walking upstairs. Yesterday, he briefly lost consciousness while carrying groceries. His temperature is 37 degrees, which is normal. Blood pressure is 118/82. Pulse is 72. Physical exam reveals a harsh, late peaking, systolic crescendo-decrescendo murmur. And even right there, that crescendo-decrescendo is going to start making me think about aortic stenosis. That's heard at the right second intercostal space with radiation to the carotid arteries, and that's the second clue of aortic stenosis. Echocardiogram demonstrates concentric left ventricular hypertrophy and abnormal aortic valve with severe narrowing of the orifices. And that's the third clue of aortic stenosis. Which of the following gross morphologies feature is most likely to be observed in this patient's aortic valve? So now that we have like a clue of what we're looking at, we start thinking about like how aortic stenosis can present and what could cause an aortic stenosis. So we're just going to start with the answer choices. So a small, sterile, wart-like vegetation along the lines of the valve closure. So that's going to be NBTE, so that's not going to be the answer because that's in the opposite direction. Next one is going to be commissural fusion forming, I don't know if I can open that. Commissural fusion forming a fish mouth or buttonhole deformity. That's not going to be the answer because that's going to be rheumatic heart disease. I'm going to put RHD for that one. C, we're going to have heaped up calcified masses on the outflow of the surface of two functional cups with prominent raphe. We're going to put a question mark by that one because that could most likely be our answer, because that sounds like calcific aortic stenosis, but we're going to keep reading just in case. Plaque-like fibrous intimal thickenings on the ventricular surfaces of the leaflets, and that's going to be characteristic of carcinoid heart disease. And then a large, friable, irregular vegetation that extends onto the chordae tendineae, and that's going to be infective endocarditis. And so now that we know that, we can go ahead and circle C because there's going to be a calcific aortic stenosis. I cannot talk today. Going back to my thinking of why I thought it was calcific aortic stenosis. So the most common cause for aortic stenosis is going to be calcific aortic stenosis, and that the clinical presentation for that is going to be the exertional angina, the syncope, and the crescendo-decrescendo, which is classic for aortic stenosis. And that murmur is going to be heard in the second intercostal space. And then there's going to be most commonly found in patients that are between 70 and 90 years old as like a wear and tear issue. And if it's seen in patients that are between 50 and 70 years old, that's going to be like the early calcific aortic stenosis, and that's going to be more of a congenital issue. But yeah, if you guys want me to go through more practice questions like this, showing you how I think through questions and how I process questions, feel free to hit that like button and leave a comment down below.